So today I'm going to talk about tremor, which is probably the bread and butter of movement disorders in neurologists. And it's often seen by your primary care physician as well as general neurologists. So today I'm going to walk you through the process on how I diagnose your tremor condition and come up with the differentials and the proper tests to confirm what you have. As I said, tremor is one of the more common movement disorders that we see in a clinical practice. And first thing I kind of look at when I see you first in my office is to see what incidences or conditions bring out the tremor. So in terms of the activation conditions, so I kind of look for a rest tremor or an action tremor. So rest tremor is at rest, when your hands are rested in your lap, or you're just standing with your hands, diving freely at your sides, and you see a tremor of one limb, and so that's called a rest tremor. So I'll show you videos in the subsequent slides though. And then there's action tremor, which can be divided into a postural tremor. So posture means you just raise your hands and keep it there, maintain that posture. Kinetic tremor means during a movement, a purposeful movement. And then there's patients that have a very specific, task-specific tremors. They don't have tremors when they raise their hands. They don't have tremors when they're at rest. But this particular task brings it out. Like for instance, one of the more common things I see is a writing tremor. And so they don't have any tremors when they're holding a glass. They don't have a tremor when they're eating. They don't have a tremor when they just have their hands stretched out. It's very specific to writing. And then there's a very interesting movement disorder called musician's tremors. Are there musicians in the audience? There you go, yeah, absolutely. So the musician's tremor is a tremor that is very task-specific to the instrument that they play. Like for instance, you can have a task-specific tremor while playing the piano, or maybe your flute, or the saxophone or something. And so this can be pretty disabling if you're a professional musician. And then there's sports-related tremor, and I think the most common thing we see is the yips. Are there golfers around here? Yeah? You know the yips, right? So the yips is when you're putting and you're holding the club with both hands, then you suddenly have a little jerking of that hand, which is involuntary. And some of these movements are dystonic, which means like spasming or cramping, whereas other patients develop a frank tremor, a putting tremor. And then I also look at the distribution. So the most common thing I see is focal tremor. So focal means it's in one body part. So for instance, just your head, or just your chin, or just your voice, or one hand, and so on and so forth. Whereas segmental tremor means two or more contiguous parts are involved. So for instance, let's say your head and one arm, or an arm and your body. So it's contiguous part. And then heavy means half of the body, so either right side or left side. And then generalized tremors would be tremors that involve your upper and lower limbs. And then we also look at the tremor based on frequency, and most of the pathological tremors fall within a certain frequency of 4 to 8 hertz. Although in my practice we see tremors of all types. So very slow means 1 to 3 hertz. So hertz refers to beats per second. So 1 to 3 hertz, and then 4 to 7 is medium frequency, 8 to 12 is fast, and then more than 12 hertz is super fast. So if I were to challenge you and raise your hand and try to beat it as fast as you can, how fast can you muster voluntarily? So most patients, unless you're Superman, can do 8 to 10 hertz. So whenever I see this super fast frequency tremors, which I'm going to show examples of, we know this is involuntary because it's really, really very difficult to generate voluntarily a tremor of 10 hertz or above. And then, as far as the other symptoms are concerned, is this an isolated tremor, meaning tremor is the only movement that I see, or clinical feature, versus is this a combined tremor syndrome? So combined means tremor plus other signs or symptoms in the nervous system. So first, this is the classic rest tremor, which we see in Parkinson's. The most common thing we see are the fingers. Maybe this can start like a twitch of 1 or 2 fingers in one hand, but can involve different parts of the body, like the hand, the arms, the legs, the foot, the jaw, and the lips. And statistically, when I see a rest tremor, and if this is the only symptom the patient has, statistically that probably represents Parkinson's disease. Or I'd have to say that about 1/4 of patients with pathology-proven Parkinson's do not have a rest tremor. Okay, and then patients with the rest tremor in the setting of Parkinson's disease also develop what is called a re-emergent tremor. So if their hand is rested, and you see this right hand tremor here, then the moment they raise the hand up, after a latency of about, I'd say about, hold on, there's some freezing issues here. Can somebody hit the video there, Larry, please? Just press on the video. There you go. Okay. So you notice that after a few seconds at rest, and then they kind of, raise their hand up, and then it kind of tremors again and reemerges after disappearing for a few seconds. So this is called re-emergent tremor. So when I see this, the most common thing that causes this is Parkinson's disease. So when I see that rest that reemerges at posture, unless proven otherwise, this is Parkinson's. And then sometimes the tremor comes out only when they're walking or distracted. Like for instance, this tremor of the right hand you see more evidently when she walks. And I have some patients where the tremor really is not apparent while they're sitting in front of me. And I kind of have to make them, walk down the hallway and see whether the tremor comes out. Now this is coming out a little blurred, but I do surface EMG, and I kind of try to measure the frequency of the tremor. Like for instance, this is a 2-second spread, and I count the number of tremor bursts that there are. So in this particular case, this is a 2-second spread with 10 tremor bursts. So this is a frequency of 5 hertz. So we have means to measure your tremor through a machine called surface EMG, which measures your tremor and kind of gives me an idea as to what kind of tremor and condition you have. And if I suspect Parkinson's, I try to look for the other cardinal features of Parkinson's. It's not just tremor, but other features, including rigidity, bradykinesia, which refers to slowness of movements, and then in more advanced cases, postural instability. And then I'm not going to go through, the specifics of treatment of Parkinson's. I just want to introduce you to, what kind of tremors we see in clinical practice. But if I suspect you have Parkinson's, then these are the most common treatment options. So levodopa is number 1, and then dopamine agonist, amantadine, and anticholinergic drugs, which are quite effective, but can cause many side effects, especially in the elderly. Okay, what is essential tremor? So essential tremor is an isolated action tremor syndrome of both upper limbs. So both upper limbs have to be involved and has to be in action. So when I see that and the duration of the tremor is 3 years or more, then I can say, okay, you do have essential tremor. Now this tremor can be associated with tremor elsewhere like the head, the voice, the trunk, or lower limbs. And the classic pure essential tremor has no other neurological signs or symptoms. So this is an example of an isolated tremor syndrome. And then if we measure the frequency of the tremor bursts, it is within the range of 4 to 12 hertz. And there's a very strong family history of somebody with tremors if you do have essential tremor or you're diagnosed with essential tremor. As against maybe Parkinson's, where the studies have shown that about 15% of patients with Parkinson's disease do have a family history. So whenever I see that, the family history, I kind of see how many generations have had the tremor. Usually with essential tremor, it's autosomal dominant, in which case about 50% of every generation will have it, or siblings or children will have it. And then there's no single gene that has been linked to ET. There's many genes that have been identified to cause or be associated with essential tremor. And classically, this kind of tremor was considered to be specific to alcohol, although we know for a fact that alcohol calms down any tremor, whether it be essential tremor, Parkinson's tremor, or dystonic tremor. And then here's the surface EMG. Again, this is a 2-second spread. And if I were to count from here to there are 14 EMG bursts, and then divided into half because this is a 2-second spread. So the frequency is 7 hertz. So this is within the range that we commonly see in essential tremor, which is between 4 and 12 hertz. Now, rarely I see patients with tremor as early as their infancy. So this is called infantile tremor. It's pretty rare. In fact, this particular condition is most commonly seen in patients with family histories of tremor, particularly central tremor. Very rare condition. More commonly seen in the Asian population. Okay, so if a patient has an isolated focal tremor, not involving the hands, is that essential tremor? So in the past, we used to lump everything with tremor as essential tremor. Especially if there's a family history of essential tremor, but nowadays we call these syndromes or tremor conditions as isolated tremor. For instance, you can have an isolated tremor of your voice, or an isolated tremor of your head, your chin, your jaw, tongue, face during smiling, or your soft palate. So I'm going to show you an example next of an isolated jaw tremor. You see the jaw going from right to left, kind of lateral movements. You know, in the past, I used to think that this was a red flag and a condition that leads to Parkinson's. Although recent pathology studies that came out of Sun City Health Research Institute showed that about 85% of these patients with an isolated jaw tremor remain isolated. In other words, it doesn't blossom into something else. Whereas about 50% of patients may develop Parkinsonism with longitudinal follow-up. So here's somebody with an isolated facial tremor. It comes out when he's smiling. Not a very common condition. In patients with essential tremor, aside from their head being involved, many patients also have either a little bit of a jaw tremor, maybe a facial tremor, and sometimes even the eyebrows may tremor. Here's another example of an isolated tremor involving the tongue. So unless I have the patient in my office, make him open his mouth, which is one of the standard things I do, stick out the patient's tongue. This is how I bring out and evaluate patients with a tongue tremor. And then what if the essential tremor patient has other neurological signs or symptoms? So we currently call these conditions as essential tremor plus or ET plus. So for instance, the most common neurological symptoms that accompany tremor would be motor symptoms like dystonia. So dystonia means a twisting of a body part. Ataxia, which is incoordination, and then Parkinsonism. But essential tremor with non-motor symptoms is also considered ET plus nowadays. So if you have ET and you develop cognitive decline or dementia, or you develop significant anxiety or depression, apathy or sleep disturbance, we then reclassify you as ET plus. And then when patients ask me, we've got a family history of ET, and we also have a family history of Parkinson's. So does essential tremor lead to Parkinson's in some individuals? And the answer is yes. So it looks like if you have a family history of essential tremor, or if you have essential tremor, you are at higher risk for developing Parkinson's or dystonia down the road. So we call that Parkinson's disease with antecedent ET. And this is most commonly noted in patients with long-standing history of essential tremors. They have decades and decades of tremor, maybe sometimes as early as their teenage years or childhood years. And I see them when they're in their 60s and 70s. They've been diagnosed as ET all this time. And then I appreciate some Parkinsonism, and I kind of say, okay, you now have a double whammy, which is Parkinson's with ET. And then rarely, if Parkinson's is the initial diagnosis, can you develop essential tremor? The answer is also yes. So you can have two conditions in your brain, both Parkinson's and ET. And the good thing is that the patients with ET and Parkinson's actually don't have a worse prognosis in comparison to just PD alone or ET alone. So here's an example of a patient with a rest tremor in one hand, has a long-standing history of essential tremor. And the question in my mind is this chronic essential tremor with some subtle Parkinsonism, which in this case is a rest tremor, or has the patient now developed Parkinson's disease? It may be confusing when you see patients like this. And mind you, the rate of misdiagnosis of early Parkinson's, or should I say suspected early Parkinson's, among experts like myself, according to a pathology study, can be as much as 42%, which is quite whopping. It's most confusing in patients like this one, where again, they start off with years and years and decades of essential tremor, and then develop some Parkinsonism along the way. So how do we differentiate essential tremor versus essential tremor with Parkinson's? So a lot of you in the audience know what a DAT scan is or a dopamine scan is, and probably have undergone this particular scan. So this is not a CAT scan. It's not an MRI. It doesn't look at these structures in the brain. All it looks at would be the dopamine signal or uptake in the so-called basal ganglia or striatum. So this is a normal DAT scan. I kind of say it's tadpole shape. You got the head of the tadpole there and the tail over here. And the head is called the caudate, and then the tail is called the putamen. So this is normal. You get to see this crescent shape or bean-shaped structure, which is bilateral. And then if you look at the Parkinson's brain, the DAT scan in a Parkinson's individual, you see loss of the putamenal signal, which is the first thing that we see in patients who are developing, Parkinson's disease. And then sometimes, the DAT scan is read as being borderline or just showing age-related conditions, and yet have a patient that's really, florid and obviously Parkinsonian. And so the question in my mind is the DAT scan really normal, or is it mildly abnormal? And that's where the skin biopsy comes in. So the skin biopsy for alpha-synuclein came about maybe commercially at least over 2 years ago. So what do we look for in the skin biopsy? So we look for a protein called alpha-synuclein. So alpha-synuclein, it's a normal protein in many of your cells, particularly in the brain. Although when it aggregates and clumps together, it forms, a pathological body called the Lewy body, which is made up of clumped up or aggregated alpha-synuclein. So we do a simple skin test. We do a punch biopsy. And then the pathologist will use a stain called PGP 9.5, which stands for nerve axons. So whatever you see green here are the axons of the nerves from the biopsy. And then next, the pathologist will stain it for alpha-synuclein. And then alpha-synuclein, it appears red. So if you see, you now compare what is green, which is where the neurons are, or should I say the nerves, peripheral nerves, with this, which is the second image, which stains for alpha-synuclein. And you will see that there is robust, alpha-synuclein in the same neurons, or should I say nerves, that were demonstrated in the previous stain. So this is how we confirm whether you truly have Parkinson's or not. However, it's not specific for Parkinson's disease. So if you have Parkinsonism and it's clinically evident, this rules in 3 conditions. So Parkinson's disease, which is the most common thing. And the second most common thing is a multiple system atrophy or MSA, which is probably the most common misdiagnosis, or should I say the closest mimic to Parkinson's out there. And then the third condition is dementia with Lewy bodies, which presents, primarily with dementia, hallucinations, and some Parkinsonism. So if you have essential tremor, and then you now develop some non-motor symptoms, which of these non-motor symptoms is predictive of possible Parkinson's, or that you are on the road towards developing Parkinson's down the road? Okay, so there's a few ones here that are very important and are highly associated with premotor Parkinson's or motor stage Parkinson's, which are, number 1, REM behavior disorder or dream acting. So at night they thrash around, they kick, they punch, they yell, they have nightmares, they sleepwalk. The second one is impaired sense of smell. Although I usually query, whether patients are smokers or have sinus conditions or a broken nose, they can impair their sense of smell, or they just had COVID, which is something that we start asking about. And then in the office, we can actually test for this. There's a smell kit called the UPSIF. So we make you scratch and sniff. There's a scratch or sniff test for this, and we make you scratch or sniff 40 items, and then there's normal scores that we look at, and abnormal scores, obviously. And in Parkinson's, the sense of smell is very impaired even before the diagnosis is made. In fact, this can start as early as 15 to 20 years before the first, motor symptom like tremor or rigidness or slowness, appears. And then there's constipation, there's visual hallucinations, and impulse control disorder. So this refers to compulsions like gambling, hypersexuality, binge eating, and compulsive shopping. And then the next type of tremor that I want to make you aware of is the so-called myoclonic tremor. So myoclonus refers to a jerky movement. So it's not a smooth tremor like oscillating movement like this. It's kind of jerky, and so this is called a myoclonic tremor. It looks like tremor though, except that we see the tremor being very jerky, and it's going to occur both at rest and during action. And if I see this kind of tremor called the myoclonic tremor or a jerky tremor in a patient who's obviously Parkinsonian. There you go. Oops. Like here, she's doing finger to nose, and you see that the tremor is kind of jerky as she reaches the finger. So she's obviously Parkinsonian. So when I see this jerky tremor, especially during action in a patient who is floridly Parkinsonian, one of the things I think about is multiple system atrophy. I rarely see this in Parkinson's, but more commonly even the early stages in the MSA. And then the tremor that is the most difficult to treat, either through medicines or surgeries, the ataxic or cerebellar tremor. It's coarse, it's large amplitude, it's slow, it's 3 hertz or less. We also refer to this as intention tremor, meaning as you reach the target, whatever the target action is, which in this case is finger to nose. See, as he reaches out for the target, that tremor amplitude just increases. So this is referred to as ataxic or cerebellar tremor. Highly resistant to most of the medicines we use for control of tremors. And then these are the drugs most commonly used for essential tremor, and we try 1 or 2 of this, sometimes do a combination if you tolerate them. But many patients with severe essential tremor, eventually after years of taking 1 or more of these medicines, start to develop some resistance. And then if you have a hand tremor, or a dystonic tremor, or a writing tremor, I also do botulinum toxin injections or Botox. You've heard of Botox, right? And some of you must have had Botox as well. Okay, so botulinum toxin injections to the arms can lessen tremor. The only downside is whatever we Botox becomes weak. So that's the issue. So it's not my favorite thing to do for patients with tremor, especially if it's their dominant hand. I reduce the tremor with the shots, which have to be given every 3 months, FYI, because it wears off. But during those 2 or 3 months, their hand grip is affected. So that hand becomes weak. So rarely do I advocate this kind of therapy. You kind of have to be desperate to get your tremor control, because there's a price to pay, and that is weakness of the hand or the fingers. Now, if you have a head tremor, I also do shots to the neck. You hear that machine in the background? That's your tremor.
You okay?
And this also needs to be given, every 3 or so months, since it wears off. Obviously, not first line, treatment for a patient with a head tremor. And then what about cannabis? Do we advocate the use of cannabis for tremor? Well, there's lots of anecdotal experience of its efficacy for tremors, whether it be Parkinson's tremor, MS tremor, dystonic tremor, or even essential tremor. But there's no controlled trials though. And so I think it works indirectly in the sense that it relaxes patients. I really don't think it has a direct anti-tremor effect. And then if you're elderly, I kind of, I'm skittish about prescribing, any cannabis product with THC. Now, if you have pure CBD, I think it's safer. And some patients do have a positive response to just pure CBD instead of the CBD/THC combination. But whenever you put some THC there and you're elderly, I just see more confusion, dizziness, imbalance, and falls, and sometimes even hallucinations or cognitive worsening, particularly in individuals who are elderly and have some cognitive conditions to start with. And then sometimes I see patients that bring a bag of supplements to my office. Literally, I had one patient, I remember very distinctly, I can't forget this one, but brought a suitcase full of supplements. It's amazing. And and I kind of combed through that entire suitcase of supplements and vitamins and good stuff supposedly for general health. And one of the things that I look for would be if they have tremor would be one of these three things. One is valerian root, which is quite sedating. Actually, used these for patients with insomnia. And the most common one that patients have experienced or tried and with positive results is tramadol. So it's a combination of valerian root, B2, B12, and folic acid. And then more recently, there's this supplement which you can even buy from Amazon, which is called Tremorate. And so this Tremorate has B12, but it also has a bunch of what they call the anti-tremor complex. So anecdotally, some of my patients have had a positive response to some of these supplements. But if you have severe tremor, though, I don't think you'll respond to any of these supplements. So maybe for milder tremors. And then next, I talk about physical measures. So we're going to talk about wrist weights and special spoons and utensils, wearable devices, and then cold immersion. So the easiest one would be wrist weights. So I ask patients to go to a sports shop or even a shop for eBay or Amazon and get half a pound to 2 pound wrist weights. You don't have to wear this all the time. You just put it on when you're doing something important like signing your checks, writing, typing, using your cell phone. And then there's fancier tremor weighted gloves. You can purchase these online. These are easy to find. Just Google tremor gloves or tremor weighted gloves, and sometimes your occupational therapist or physical therapist will even make some of these gloves for you, and it's like tailor fit to your hand, as well as tailor fit to the amount of weight that needs to be put. And then, like for instance, there's this orthotic glove, which is it can be purchased online called Ready Steady. It's custom made.
The patient's hand and does not restrict.
It's custom made. It's moldable and fitted to the patient's hand. It does not restrict range of motion. They have full finger, full wrist range of motion.
And it's also easily customizable. Different amounts of non-toxic weight can be added or taken away depending on disease state, medication changes, and other factors.
Here's an actual patient that was fitted with the Ready Steady. You see him first, struggling to hold that spoon and eat. And opening a jar is quite difficult. And then with the glove on, he's able to control the tremor or dampen the tremor. So this is most effective for patients with essential tremor, not so much Parkinson's tremor, and not so much dystonic tremor either. So this is a Ready Steady. Okay, this is more fancy. This is available in the UK. It's called a gyroscope tremor glove. So first you see her trembling. I got this from YouTube. I don't think this is available in the US though. Although you can contact them directly. Sometimes they do.
Essentially, you have a little hook which sits on the back of the hand. There's a spinning flywheel, and that's sits on the back of the flywheel. It exerts a gyroscopic force. So much like a spinning top, that will always stay upright as long as it's spinning. Your hand will always stay level while the flywheel is spinning.
So this runs on batteries, so it's like a spinning thing inside, and when you raise your hand, the spinning thing actually stabilizes the hand tremor. Now the next even more common thing we see are just tremor utensils, spoons, forks, and knives you can buy online, even from Amazon. I think they're like about $200 or $300 each. Each utensil, we're talking like, the spoon is about $200 or $300, and then the fork is another $200 or $300. It doesn't reduce the tremor, it just reduces the impact of the tremor. If you notice, the hand is still tremoring, but the distal part of that utensil, which is the spoon or the fork, shakes less. So it sends a counter force. So if your hand is going up, it sends a counter force going down And so the net effect is that the distal part of the utensil shakes less. And then I'm going to encourage you to, check out the tables. One of the tables has the Calatrio. So this one is run by a battery. So I'm going to make you listen.
Peripheral nerve stimulation through the wrist. Surface stimulation is delivered to the median and radial nerves, disrupting the pathological tremor frequency signals. This effectively addresses the variability of your patient's condition, resulting in a meaningful reduction of the tremor for a period of time. Will symptom improvement using Calatrio therapy at home. 68% of users reported improvement in activities of daily living, most notably in handwriting, holding a cup, and using a spoon.
Okay, so the median and radial nerves go through your wrist over here. And there's a third nerve called the ulnar nerve. So there are three nerves that innervate your hand. The median, radial, and the ulnar nerve. So this stimulates two of those nerves called the median and the radial nerve. And then this impulse is transmitted to the part of the brain called the thalamus, which controls tremors. And in fact, if you have deep brain stimulation or are considering deep brain stimulation for essential tremor, the target in the brain is the thalamus, the VAM nucleus of the thalamus. So this sends, and it gets transmitted to the thalamus and calms down your tremor, for a considerable number of hours, depending on how frequently you use it, how much you use it. So the statistics show that about 54%, or more than half of users experience a 50% reduction. Overall, about 92% of patients have shown some tremor control, and about 1/4 of patients have at least 70% improvement of their tremors. So this is Calatrio. And then there's another device called the Tremolo, and this is also available for purchase. Whereas the Calatrio needs a prescription for you to be able to purchase. So your doctor has to agree to that therapy and issue a prescription. This one you'll need a prescription for. You can literally buy this yourself, from the internet. So I'm going to show a video since it really speaks 1,000 words and very nicely describes it.
Countering the tremor in a person's arm. Using the tuned mass damping principle, sets a shifting weight system of smooth blood, create forces in the opposing direction of the tremor. This is the principle used to stabilize vibrating aircrafts and skyscrapers in the events of high winds or earthquakes. It absorbs the tremor in a person's arm without the use of any electricity, meaning no charging is required, and there are no issues for DBS patients. We launched a statewide research study involving 125 patients. We tested the Tremolo with 36 patients who suffered from action tremor. The device proved to be successful, reducing people's tremor by up to 80%.
So this is purely mechanical. There's no battery. So it works on the principle, of weight, the same weight kind of strategically placed that dampens the tremor. Since it's like a shock absorber, so to speak, for tremors. Okay, the next device is called the Steady 2. Can we press the video on this one, please, Larry? So this works through a magnet and a disc.
I have had essential tremor. The one problem I had with it was people would think I was nervous, and people would be saying to me, "Don't be nervous, don't be nervous," and I wasn't nervous. As I got older, into my 50s and 60s, it did become more of a problem. But my biggest issue is my hand shaking, because it stops you from doing things you want to do. And I do jigsaw puzzles, I watch TV, I read, I play games on my iPad. And one thing with the computer is I'm multitasking all the time that I don't want to be, and it's still frustrating. Online, the International Center for Tremor Foundation, they send out an electronic newsletter that's called the Tremogram every month. That's how I found out about Steadywear. When I saw a write-up on it, I immediately got on the phone, phoned them, and asked if I could order one. The glove made a difference I can play games on my computer really much better. Oh, just, I'm winning. I'm feeling more comfortable. Even the rest of me feels like I'm not tremoring as much. And it may very well be, but it doesn't feel as though I am.
So most of these wearables are kind of bulky. They're kind of big, right? So it's kind of awkward using these devices in public. You know,
Here.
I think these are best worn in the house. But they work though. They do work.
And that's it. That's it.
Okay, and then I'd like to talk to you about cold immersion. You know, one of my pet projects when I was a fellow and then when I was a junior attending at the Mayo Clinic was to experiment on cold immersion. So what I did was I immersed the hands, or should I say the forearms, of patients with Parkinson's and essential tremor. Both first the cold and then the next time, you know, hot, warm water. And then I compared the effect of warm water immersion versus cold water immersion on their tremors. And what I discovered was that patients with essential tremor actually do very well with cold immersion. So it has to be pretty cold. So literally, you drop, you know, ice cubes in a bucket or a bin or something, which in this case is a sink, and then just immerse your forearm, should I say, not just the hand. It has to be the entire forearm and the hand. For about 10 minutes, and then it lessens the tremor. In my project, it lessens the tremor for about 90 minutes. Again, nothing to wear. This is easy to do even in your home, in your kitchen, and it works. But this is called cold immersion. If you have Parkinson's, though, don't do this because it makes the tremor worse. So I found out that for patients with Parkinson's, the warm immersion works better, whereas for patients with essential tremor, it's the opposite. It's cold immersion. And this was triggered by comments of my patients, since we see a lot of snowbirds here in Arizona. So at some point, I kind of asked my patients, so where is your tremor better? Is it better whether you're here in Arizona versus there up in Minnesota? And so the result of that, you know, informal survey or poll that I did was that many Parkinson's patients prefer being warmer weather, meaning here, whereas many patients with essential tremor prefer, you know, being in cold weather because they notice their tremors to be better. And then next, I'm going to talk about enhanced physiologic tremor. So believe it or not, all of us in this room are vibrating at this point. So all of us have a little bit of a fine tremor, except that it's so mild and it's so fast and it's so tiny that we don't see it. Only when the tremor becomes more obvious and is brought out by certain things like fatigue, you being very anxious, very nervous, having too much caffeine, taking an exam, being stressed out, or taking some medicine, or maybe having some thyroid conditions, especially hyperthyroidism. These conditions then bring out or enhance the physiologic tremor that all of us have. So, for instance, if you're angry, you start, shaking, right? You're so angry that you're shaking. Or if you're cold, it's really cold, you start shivering. So, shivering is a form of tremor. So, all of us have that background physiologic tremor, which is enhanced. So, this is kind of fast frequency. If we measure this is about 8 to 12 hertz. So, here's an experiment I did on myself when I was a fellow. So, coffee was bountiful during my fellowship. There was a coffee pot and the entire day at work. So I was curious as to how many cups of coffee would bring out my physiologic tremor. I found out that 5 cups would produce this. So that's my hand. That's my hand after 5 cups of coffee. First I tried 1, and then 2, and then 3, then 4, and finally my threshold was 5. 5 cups of coffee. So if you have too much caffeine, and in fact, some of my patients with essential tremor or even Parkinson's tremor, one of the things they do is just cut out caffeine from their diet, and their tremors improve. I think a cup or 2 would be okay, but anything above that can be worsening your tremors. And then one of the first things I look at, and I always look at this very patiently, would be the list of drugs that the patients are on. Because before I go on a $1 million workup trying to see whether you have Parkinson's or atypical Parkinsonism or essential tremor, I kind of want first to see whether you're taking some medicine that may be causing tremors. Like for instance, the most common ones that I see are the so-called atypical neuroleptics, and these are supposedly safer in the sense that they cause less drug-induced movement disorders, but they're not that safe. They're not 100% safe. So many of my patients still develop tremors from risperidone or olanzapine or geodone or abilify. These are the so-called atypicals. And then if you make a trip to your GI doctor because you're nauseous, you have stomach issues, or you go to the ER for whatever and you're nauseous, the first thing they prescribe is metoclopramide, which is a very cheap anti-nausea medicine, except that it is a dopamine blocker, in which case it causes tremors. And so one of the first things I look at and do if I see this drug in the list is to say, okay, we got to shift it to something else. And I betcha, if we do that, the tremor will reverse over time. And then there's valproic acid, which is a seizure drug. It's very commonly used for bipolar disorder as well. And then there's a heart medicine called imiodarone, very commonly prescribed for atrial fibrillation or atrial flutter. So when I see that, and they've been taking this for at least 3 months, I kind of say, okay, is this possibly contributing to your tremor? And so this is where I kind of ask the patients to talk to their cardiologist and see whether there are safer alternatives. And then there's lithium, which is used for bipolar disorder. There's stimulants like Ritalin or methylphenidate. And then there's antidepressants, and then there's caffeine. All of these can cause tremor or worsen your underlying tremor. Now there's this interesting tremor condition called the rabbit syndrome. So the rabbit, if you notice, has a constantly moving nose and mouth, right? Even at baseline. So you see here a vertical movement, of the chin and of the lips. So whenever I see that vertical movement and I estimate this or I measure this with surface EMG, the frequency is about 5 to 6 hertz. Then I kind of say, okay, this must be drug-induced. So this is a drug-induced tremor, usually caused by antipsychotic drugs. And this is reversible. And then next, I'm going to talk to you about an interesting tremor condition. It's not as uncommon as we think it was. And in fact, if I were to do surface EMG on every patient of mine with Parkinson's or patient of mine with hand tremors, a good percentage of them have orthostatic tremor. So this is tremor of your legs when you're standing in place. It doesn't occur when you're walking. It doesn't occur when you're in bed. It doesn't occur when you're in a recliner or in your chair. It only happens when you're standing. And this is a really fast frequency tremor. It's 13 to 20 hertz. It's really fast. And the way I diagnose that is, first I look at your legs, and I see, if you see this individual, the moment he stands up, he has these shaky legs. And sometimes I even, get my stethoscope, and I put my stethoscope right there in the leg, and I hear a sound that sounds like a helicopter. So whenever I do that, and I kind of see this kind of tremor, and I measure it, and it measures 13 hertz or more, I diagnose the patient with orthostatic tremor. And this causes imbalance or difficulty standing in place. And if I measure this, again, this is a 1 second spread, and these are the extremity muscles. So this is about 15 hertz right there, I think. Or 14 hertz. It's 15 hertz. Okay, and then the other tremor I want to talk to you about would be dystonic tremor. So dystonic tremor means tremor in a part of the limb, or the body, I should say, or even the head with dystonia. And this is frequently mistaken as either essential tremor or even a Parkinson's tremor. So for instance, here's somebody with essential tremor with a head tremor. There's no twisting, there's no posturing. There's no turning of the head towards one side. So this is just head tremor from essential tremor. And yet, and then if I do electrophysiology and I measure the tremor frequency, it's 4 hertz. So the head, it's kind of slow when it do tremors. It can tremor very fast. So 4 to 6 hertz is the usual, head tremor frequency that I see. And then you see this individual with turning of the head towards the left. It's involuntary. And you also see that head kind of tremors, to and fro horizontally. So this is called a dystonic head tremor. So it is a tremor in a part of the body that has dystonia. So dystonia refers to spasming or twisting or turning of a body part. And then when I do electrophysiology, I see this so-called dystonic spasm. They're prolonged spasm rather than a brief tremor burst. That's how I confirm that, especially in more subtle cases, in cases less obvious than this, That's how I confirmed that this is truly a dystonic type of tremor and not just a central tremor. So here's a patient with dystonia of the hand. So you notice the fingers go up involuntarily. At the same time, you see a tremor right there. Has been diagnosed as a central tremor by many doctors in the past. And none of the medicines for tremor improved the hand tremor. Because this was not a central tremor. This was a dystonic tremor. And in fact, here's another one, which is even more common than the one I just showed you, which is flexion of the hand and a hand tremor. Now, this one is so commonly mistaken as the beginnings of Parkinson's. And yet, we do DAT scans on these patients. Their DAT scans are normal. Then we throw some, medicines for Parkinson's. They don't respond. So when I ever see that hand that's tremoring and I kind of see, wow, this hand is kind of twisted or flexed or postured, then I kind of say, okay, this is not a Parkinson's tremor. This must be a dystonic hand tremor. And then if a patient comes to me and I make a diagnosis of a dystonic tremor, these are the drugs that I usually or commonly use. So I go to botulinum toxin injections when the others have failed. But again, if it's the hand though, I counsel the patient about the weakness. So here's the same individual 2 slides ago after Botox. You see that right hand really calmed down, right there. Although he had these injections for 2 or 3 times and he stopped coming because it made his hand really weak. So that's the downside. Okay, psychogenic tremor. It's more common than we actually think. And this is one of the potential causes of poor response to medicines. And mind you, I've even seen patients that made it to deep brain stimulation and have psychogenic tremor. So, we have tricks under our sleeves. We kind of do electrophysiology on this kind of patient. We see a very variable frequency. It's distractible. It gets entrained with purposeful movements of the opposite limb. Mostly commonly seen in younger individuals and more common among females. So psychogenic tremor. Usually abrupt onset. So for instance, an essential tremor doesn't suddenly overnight, have a maximal severity. First it starts very mild and increases with time. Same thing with Parkinson's tremor. But with psychogenic tremor, they literally just switch on overnight. From none to very severe. So whenever I hear that sudden onset of tremor and then I do a brain scan and there's nothing there that suggests, a stroke or a pathology, then I confidently, will say, most likely, psychogenic tremor. And then Dr. Ponce will take a deeper dive into deep brain stimulation in a few minutes, but I'm going to just show you some of the patients we've done together. So you see that left hand tremor. She also has a head tremor. It's not very obvious here because, there you go. Even if her face is blurred out, you still see her head shaking, right? And then and here she is holding a cup, which she struggles with in that tremulous hand. Very difficult. And then when deep brain stimulation was done of the VIM, there's remarkable improvement. So for midline tremors, meaning your voice or your head or your trunk, you need both sides to be done. You cannot have midline tremors sufficiently controlled with just one side being done. Okay, here's somebody with tremor predominant Parkinson's. So for patients with severe tremors, sometimes don't respond to levodopa or the medication we use for Parkinson's. Especially if they have this severe re-emergent tremor aside from the severe rest tremor. Many of these patients just need whopping doses of medicines which make them fuzzy-minded, sleepy, nauseous, and so on and so forth. So these are the type of patients that make it to deep brain stimulation sooner than later. And then this is, I'm going to show you next this video, I'd say about a month after DDS. So a remarkable improvement of tremor. And many of these patients with tremor predominant Parkinson's, we just discontinue all their medicines after DDS. Okay, one of the more difficult ones to treat, it's called Holmes tremor. It's also referred to as rubral tremor or midbrain tremor. It's a coarse, proximal, and distal tremor. It occurs at rest, posture, action, and intention. It's low frequency. It's very disabling. Very hard to treat with medications. It's called a Holmes tremor. Many of these patients just shake from head to foot. And this is after deep brain stimulation with Dr. Ponce. It's remarkable. Although many of these patients have some ataxia. Ataxia means incoordination or cerebellar signs. The cerebellar signs or symptoms don't improve. It's the tremor that improves. So we know there's a little bit of ataxia there. It's kind of searching, for his mouth. So it kind of goes from side to side. So this improves tremor, but it doesn't improve ataxia. Here's somebody with a severe head tremor from dystonia. This is with the DBS stimulator off. It's quite severe. So those with cervical dystonia, I think the ones most responsive to DBS are the ones with a tremor, a strong tremor. Those that are kind of fixed towards one side or twisted towards one side are less responsive. Whereas patients like this particular chap, this is now with the stimulator on, it's remarkable how their tremor improves. So if you have a head tremor, really the differentials would be essential tremor versus dystonic head tremor. So it's very important to make that distinction. And then Dr. Ponce and I published about a couple of years ago our series of patients with orthostatic tremor persistent to medicines. Rare condition, very few patients have made it with deep brain stimulation. So this is him trying to stand and keep his balance. His legs are shaking, he's very unsteady. And we tried everything in the books, medicine-wise, to help the so-called shaky legs. So when they're walking, they're fine. They have no imbalance when they're walking. It's only when they stop. So you see him stop here in the hallway, and he now needs to hold on to the walls. So really, many of these patients with orthostatic tremor, all they have to do is not stop walking, right? Instead of, if you're falling in line, just keep on walking. Or just keep on marching in place. Some patients just march in place and they're fine. They look awkward though, but it works. And this is him after DBS. It's remarkable. I mean, he also had hand tremors, but hand tremors are easy to fix. But orthostatic tremor, very difficult to fix with medicines. And yet with DBS, the improvement is remarkable. I think we last saw him like a few months ago, and that was maybe 6 or 7 years after DBS. So the effect seems to be enduring and long-lasting. What about ET? Does it last? So this is an individual that we did more than 10 years ago when the video was done, and this is the stimulator on. So we do an on-off testing every now and then this is the stimulator off. Let me just forward this. Here, this is off. So we know it's working. And many patients, when they switch off their stimulator after DBS, they kind of see just how bad their tremors are. And then we kind of say, okay, if you didn't have DBS, this is how you would be at this point. It's very remarkable. So very few patients develop a tolerance to deep brain stimulation. Some of those that develop a tolerance are those with the Holmes type of tremor, which I just showed you a while ago. Okay, here's a task-specific tremor called primary writing tremor. She doesn't have a tremor when she holds on to things, or raises her hand, or eats. It only happens when she's writing. She happens to be a high-level personal secretary of a CEO, and so she needs her hands to be steady when she writes. She does a lot of transcribing of meetings and notes and all that. Now this is one of the few tremor conditions where I probably would want this to be done awake. As Dr. Ponce will tell you in a few minutes, DBS now is done asleep with practically the same results as done awake. So, during the operation, once we hit the sweet spot, we make her write, and we see an improvement of the tremor. It's so gratifying to see this dramatic change even in the operating room. Okay, so these are the tremors which are responsive to DBS: Parkinson's tremor, essential tremor, dystonic tremor. And then if you don't want DBS, and Dr. Ponce will talk about this in a few minutes, what are the options? So he'll talk about, in particular, focused ultrasound. But there are other options there. And then if you want to learn more about DBS, we hold classes every 6 to 8 weeks. Just contact our office and we'll sign you up. So I'm going to end here, and I'm going to pass the floor and the baton to Dr. Ponce. And he's going to talk to you more about deep brain stimulation and focused ultrasound. Then we'll regroup again. We'll do questions and answers.